Good afternoon, everyone. Today's lecture will be by Dr. Subin from Radiology. He'll be continuing his lectures on thorax imaging. Today, he'll be mostly focusing on the CT and other modalities of imaging with respect to thorax. Kindly, if you have any queries, please drop into your chat box, or you can ask through the lecture or by the end of the lecture. And this lecture will be finally uploaded later on in the medicine YouTube website. Stay tuned, guys. Bye.
Hi. So I'll be talking a bit about CT thorax. Just the basics. I'll just go through how to just run through the CT thorax, like what are the basic things that we look at, and like maybe go through some pathologies which we try to identify on CT. There's a feedback. All right. So um, CT was actually discovered by this guy called Godfrey Hounsfield. It's almost like decades ago, like in 1972. He was a British engineer, and him along with one guy called Alan Cormack. They both received Nobel Prize for this, and they like developed this CT machine. The first CT machine looked like this. You could only put the head inside. It was like primarily meant to take for CT brain. In fact, the first CT was done on a patient with a brain tumor. It took, I think, days or hours, I guess, hours to actually take the image, because it would take each slice one by one, and each of that would had to be reconstructed. Each of it used to take time, and then it used to take days to actually get the final image. So that was the first CT. As compared to now, we have these modern CT scanners which like take the whole picture of the moving heart in less than 1 second. So CT is of three different types. One is the standard, the types of CT that we take. Is different types of CT that we take. One is the usual standard CT images that we take, which are usually like 3 to 10 millimeter of slice thickness. These are like thicker sections, and this is what we use for most of the routine CT investigation. The other thing is a high resolution CT that like gives you thinner sections, and HRCT does not involve contrast, while standard CT may or may not involve contrast. If you want to do angiography, which is basically thinner slices in arterial or in venous phase, and that is given with an IV contrast. So these are the basic kinds of CT techniques that we use. The thing is that this thing of 3 to 10 millimeter and all is like all reconstructed images right now. Like for example, the CT machine that we have in room 22 is like the minimal slice thickness that you can get is 0.625. So the machine automatically takes images at 0.625 resolution, and we reconstructed it and send it as 2 millimeter or 2.5 millimeter or HRCT sections, which might be thinner, 1.5 millimeter, or you can take thicker sections. So the computer will reconstruct the images and send it. So just because CT thorax is done doesn't mean that we might not be able to get an HRCT image out of it. We can still get thin sections out of it because the raw data is actually thinner sections than that. Okay, so that's about CT. So why do we actually give contrast? It's actually to make out differences between different types of tissues, mainly for evaluation of the mediastinum, because the heart and all takes up blood, and the great vessels also take up blood. Infections of the chest wall also, like any infection, not just chest wall, even inside the lung, any kind of infection, it's always good to do a contrast CT. Of course, malignancy is definitely one of the things. Evaluation of pleura, mainly thickening, nodules to see empyema, pleural metastasis. In case of a lobar collapse, that's what I've showed here. So there is this atelectasis. So the lung, when it gets compressed or collapsed together, it will enhance quite nicely, and the effusion which is around it will look less dense, because contrast doesn't go into the effusion. So like if you could take a non-contrast CT, it might be difficult to make out the difference between that. And secondly, like if there is a mass inside this lesion, suppose there's a mass inside the lung, it is going to look less dense as compared to the rest of the lung, because lung has a lot of vessels. It's quite vascular, so it'll look more white. And if there are hypodense areas which are seen, could be infection, could be some mucus plugging, or it could even be malignancy. So that is the advantage of taking contrast. Other important thing is to differentiate between nodes and vascular structures. So whenever you have nodes, when you need to see look for thoracic adenopathy in case of lymphoma or any of those things where nodes is required to be evaluated, you have to give contrast. All right. So, what are the additional sections that we do other than the routine CT scans that we do is prone sections. Prone sections basically we usually do in case of ILD. Like suppose you find subtle ground glass density at the base of the lung. The base of the lung, because of gravity, there will be more of pooling of the blood, or the lung parenchyma will be more compressed. So that might give you an appearance of a ground glass opacity. So when you make the patient prone, that the changes which are because of gravity will go. If there is a real ground glass opacity, it will be apparent in that. So that's why I do prone scans. Then expiratory scans is to look for air trapping, like for example foreign body, or like asthma, or some in case of some bronchiolitis kind of cases, or in hypersensitivity pneumonitis. All these cases we do expiratory scans to look for air trapping. So what happens in air trapping is that, like when you expire, if there is a bronchial occlusion, um, sorry, yeah, if there is occlusion of the bronchus, then the air doesn't move out. The air stays inside that place. That segment which is like supplying that supplied by that bronchus will remain the same, or it gets hyperinflated as compared to the rest of the region, where air goes out and it will look less dense. So routine CT protocol, we usually cover from apex to diaphragm. Like in case of malignancies, we cover the adrenals as well. And we sometimes do a venous phase also through the liver and the adrenals in case of its malignancy, because liver lesions, adrenal lesions are better seen in the late or the delayed or the venous phase. All right. So there are different kinds of section views that we use. One is axial, which is what you're seeing on the left side. These are coronal sections, and these are sagittal sections. So we use these different sections. All the three sections we use to like view and find out, okay, what is the abnormality, and we have these different windows which we follow. This is a bone window where the bone becomes more apparent and lesions in the bone are seen better. This is the lung window. These are all settings which you can make on the monitor itself. So lung window, in which you'll be able to see the lung vessels, lung nodules, and lung parenchyma, the interstitial and all better. Then there is the mediastinal or the soft tissue window, where you'll be able to make out the soft tissues much better. So use evaluation of each of these structures, use these different windows. All right. So the basic principle behind CT, or rather is basically CT uses X-rays. So the X-rays pass through the body.
Ask will get from there. Huh?
Yeah. X-rays pass through the body, and there is attenuation of these X-rays, and the CT machine will calculate how much of attenuation is there. So each of those points in your body is given one number. That's called HU, Hounsfield units, named after the guy who discovered CT. So the computer will, like, it's a complex algorithm with which the computer will decide, okay, this point has to get this much value, this point has to get this much value, depending on the amount of attenuation which comes through the it's basically X-ray itself. However, it uses these Hounsfield. I'm just telling it for you to understand. So I'll just run quickly through some little bit of anatomy. So this is the axial section. This is how an axial section will look like. This is the superior part of the mediastinum, where you can see the trachea and the great vessels. You can see the subclavian arteries on both sides, jugular veins, and these are the medial ends of the clavicle. And this is the apex of the lung. As you come down, you'll see more of the lung. The trachea is still seen, and you can see the left brachiocephalic coming towards this side, the right brachiocephalic on this side. And most of the times you'll find contrast in one of these veins, depending on which side the contrast has been given through. In the arterial phase, these CT thorax is always done in an arterial phase. So in the arterial phase, you'll be able to see these vessels quite dense, because contrast will be there within these vessels. So you will also be able to see these internal mammary veins as well, which are behind the sternum. So these are the spaces, the anterior mediastinal spaces. These are the paratracheal regions on both sides. Um, this is the arch of aorta, and here we say the para-aortic region. On this is also a prevascular compartment. This is where a thymoma and all will be seen. Here again, paratracheal nodes can be there. This is the region of the esophagus, and here would be the esophagus vein. So that is after the just below the bifurcation. So this is the subaortic region, or the AP window nodes and all will be seen. That is between the aorta, the arch of the aorta, and pulmonary artery, which will start coming just below this level. And that's the descending aorta you are seeing on the left side. So in CT, you remember right is always on this side and left is on this side. All right. So after you start seeing the aorta, you start seeing the pulmonary artery. The aorta is always on to the right of the pulmonary artery, and that is the main pulmonary artery. That is the right ventricle. So if you trace the right ventricle up, it will lead into the pulmonary artery. This is the left pulmonary artery. Sorry. And this is the right pulmonary artery. Okay. So okay, that's the right pulmonary artery. So when you look for pulmonary embolism, these are the main vessels that we look at, and we'll follow these vessels along the course of these vessels, each of the branches of these vessels, to see if there is any thrombus in pulmonary embolism. All right, so that's the left atrium, which is posteriorly located. That is the aortic root. This is the left atrial appendage that we are seeing. Again, the aortic root, you can see the coronary vessels which are starting. This is not the, so CT thorax, plain CT thorax is not really used for assessing the coronary vessels. You need to do a coronary angiogram for those, but you will be able to see vessels in some, like maybe not very clearly, but you will be able to see vessels, and you might be able to see calcification. So this is the LAD, which goes between the right ventricle and the left ventricle, and this is the RCA, or the right coronary artery, and the LCX will be going in the group between the atrium and the ventricle on this side. That is the left circumflex artery. All right, so this is the view in which the heart is seen best. So that's the left ventricle. You can see the wall of the left ventricle on this side, and the right ventricle is the left ventricular outflow tract. On the right side is the right atrium, and left side posteriorly will be the left atrium. Here you see the pulmonary veins draining in, and so um, like pericardium is another thing that we look at. So pericardium is usually seen as a very thin line like this. So this thin line, usually less than 2 millimeter it is, and that is a pericardium that we are seeing. If there is thickening or effusion, this is going to get thickened, or there will be more hypodensity which is seen along this region. And if it is fluid, it will be of low density. If it's hemorrhage, it will be a bit more higher density. If they are masses or anything, you need to give contrast, and they will enhance, and they will have these nodular patterns if you have pericardial metastasis, or sometimes you'll be having pericarditis, where you have thickening of the pericardium as well, which will be diffuse thickening of the pericardium, which will enhance. All right. So that was just about vessels and the heart. So lungs, like the way we look at it is to divide it into segments. So like there are 10 segments on each side. I'm not going to go into this, but basically there are 10 segments on each side, and we describe like the location of the nodule, or whichever lesion is there, depending on which part of the segment is involved. So these are the segments. I think you can probably look it up later. I don't think this is important for you. So the bronchus, this is the lung window that I'm talking about. So the previous ones, whatever I showed you was mediastinal window. This is lung window, where you see the lungs well, and the bronchus will look like black things with a ring around it. So these are the bronchus. That's the esophagus on this side, and this is the trachea. So in lung window, you won't be able to see the mediastinal structures properly. You'll be able to see the lung nodules. All these tiny, tiny dots that you're seeing are all vessels. So if these things are continuous, when you scroll from top to bottom, that means it could be vessels. If they are non-contiguous, if you see one single dot, those could be nodules. If they are bigger lesions, then it could be masses. So um, that's how you differentiate from bronchus versus vessels. Um, So that's the level of the carena, where you see the right main bronchus, left main bronchus, that's the bronchus intermedius. And these things, lines that you see, these are the fissures. These are seen on both sides, which is separating the right middle lobe and the right lower lobe. Here again, the left upper lobe and the left lower lobe. All right. So just to like recap from yesterday, if you remember, the right middle lobe was touching this right side of the heart. So this is how the right middle lobe is sitting, and that is why you have the silhouette of the right heart border on this side, because the right middle lobe is sitting here. So if you see the left heart border, this is the lingular region. This is the lingular, which is touching the left heart border. So if there is an opacity, if the right heart border is not very clearly visualized, it could be in the right middle lobe. Left heart border not being visualized, it could be in the lingula. All right. So those are the major fissures which you see. These should be really, really thin. Sometimes you'll be able to see nodularity, like sometimes you'll be able to see some effusion along this fissure. So that's about fissures and lung parenchyma. Then nodes, I think nodes have very, very complex classification which is followed. But essentially, just like for you to remember, just remember trachea. On either side of the trachea will be paratracheal, and then adjacent to the aorta will be this para-aortic region. Anterior to all these regions will be prevascular. Then lower down below the carinal level will be subcarinal, and where the hilum is seen will be hilar, which is quite self-explanatory. If you go lower down, you will have these para-esophageal nodes and all these things. All right, so how do we evaluate the CT is like we have, again, just like X-ray, we have a protocol. We'll go through each area by itself. So you can like start with the trachea, go down to the bronchus, then see the parenchyma, lung parenchyma, then see the vessels, or whichever way you want. We need to like have some protocol regarding it. So this is just to show how reconstructed images can be used to see this tracheal involvement in a vaginous. This is a subglottic stenosis which is seen in a vaginous granulomatosis. These are axial images where you can see these granulomatous lesions which are seen within the tracheal lumen. And this is the coronal section which shows that that's narrowing is present. This is just a reconstructed image. Okay. This again is to just to show you, these are coronal sections. This is just to show you the importance of doing contrast. So you can see that the vessels are seen, and these things are seen separate from the vessels. So these are nodes. All right. So that's why if these were not filled in contrast, it would be quite difficult to differentiate between the hilar nodes and these vessels. So that is why it's important, whenever there is nodes that you need to evaluate, or any vascular structure that you know evaluate, make sure you send for contrast imaging. All right. So this again, just to show you the importance of contrast. This is the pulmonary artery. You can see that the pulmonary artery is quite big. So normally the pulmonary artery is smaller than the aorta. If the pulmonary artery is bigger than the aorta, we usually write it as dilated main pulmonary artery. Of course, you have to correlate with echo for the presence of pulmonary artery hypertension. But this is the patient who actually had pulmonary artery hypertension. If you can see, this is the main pulmonary artery. This is the AP window region which looks bulged on this side, and this is the descending pulmonary artery on the right side, which shows dilatation. So it's a case of a pulmonary artery hypertension. You can also see there is sudden pruning of these vessels. You can see abrupt, like suddenly the diameter of the vessels has reduced in size. All right. This again is to this is just a mass. Why I'm saying this is because this is in the hilar region. So this is how a hilar mass will look like. It will be very close. It can have, this is malignant region. It can have this spiculated appearance, and again you need a contrast to evaluate this properly. All right. So what are the other lung abnormalities that we look at? So we saw about trachea. I showed you a small few things about the hilum. So in the lung, which is the main part of where you are going to like evaluate for a CT thorax, we look for consolidations. Okay, where like these are all the things which will be more bright on a CT. Like it can be consolidation, it can be interstitial opacities, it can be atelectasis, or it can be a nodule or a mass. The things which look low, dense, are cyst, emphysema, and cavity. Okay, so these are the things that you look at, and you evaluate according to which segment is involved and how. We'll just go into how each of these things look like. So first of all is consolidation. So same like how you saw in X-rays, air bronchograms. These are the air bronchograms that you're seeing. This is an axial CT image. This is an axial CT image. Can you just mute this? Yeah, it's muted. Thank you. Yeah, so this is consolidation where you see air bronchograms. So this is the bronchus. So you can see the bronchus seen separately from this area, which is looking more dense. So this consolidation looks more dense and the bronchus will be seen through it. This was a case of pneumococcal pneumonia.
What is the cell is a bleed from
And this again, I'm just showing opacities which are consolidate similar like consolidation. These are peripheral kind of opacities. This is called reverse battering opacities. It can be seen in like a lot of things like organizing pneumonia or chronic eosinophilic pneumonia. Um, and this is the usual battering opacities. You can see that the peripheral area is spared and the center area is involved. So this is a battering opacities which are seen in pulmonary edema. Right. So yeah, other than consolidations, you can have nodules, like you can have cavities. So sometimes these consolidations will have this air lucency within. So when there is a consolidation or a wall like a cavity with air lucency, we call it as a like a air filled cavity. This is a thick walled cavity, and you can see there are these dots which are seen like this multiple dots. This is the normal lung, how it will look. So you will have these lines which are the vessels, and peripherally you shouldn't be able to see anything else near that region. And these are the nodules. Okay, so this is what we typically call as central lobular nodules. Okay, if you imagine them to be like branches of the trees and buds, this will be like tree and bud appearance. Okay, so we'll probably like think of a TV cavity and nodules inside the lung, which is involving this region of the lung. This was a pulmonary TV. All right, so tree and bud usually like just doesn't always mean TB. It can just mean anything which has an endobronchial spread. It can mean metastasis, it can mean TB, it can mean some bacterial infections, it can mean sometimes some fungal infections. So the important thing is to like realize that okay, this is probably something acute if it comes in a in the correct clinical setting, and probably you need to go a BAL or a TBL to evaluate further. This is how a miliary tuberculosis will look like. Again, multiple nodules which are scattered. These are not 100% clean, but as such, this will be like more like random distribution. It's there everywhere. Okay, this is again another cavity, but this is a cavity with this air crescent sign. So like what we see on aspergilloma is like in the healing phase, there will be this presence of this air crescent. So normally like after we do this CT, you can always take prone sections. Like when you take the prone sections, it's a fungal ball. So it will move to this side and you'll see the air crescent on this side. So you can demonstrate that. That's the air crescent sign that we'll see on aspergilloma. So if you are suspecting a fungal ball, sometimes you might call the patient back and then ask for prone sections in the second time. All right. So that was mainly about the parenchymal abnormalities. I will just quickly go through interstitial disease. I think this is like quite difficult for many people to understand. Like, so interstitium is basically the spaces which like surround this secondary pulmonary lobule. If you remember the secondary pulmonary lobule from your is a secondary pulmonary lobule. So it has the terminal bronchiole, it has the arterial branches, and it has these bronchioles, and these are the acinus. Okay, the interlobular septum will be in this. Okay, this is the interlobular septum that we are looking at. So, and in an HRCT, you're going to be able to see these lines. These are the interlobular septae, and if these are thickened or if they are reticular lines, we'll be able to see these lines. And if there are if nodules or anything are seen around this region, Centrilobular we call it as centrilobular nodules. If they are seen around the peripheral part, they are called as perilymphatic, because lymphatics are present. It's called perilymphatic nodules. And if they are randomly distributed in multiple places, then we call it at random nodules. So depending on the area of involvement, you can say if it is an airway disease, or it will probably like related to lymphatics, the central lymphatics. So like for example, like hypersensitivity pneumonitis, respiratory bronchiolitis, and all can have centrilobular appearance of the pathology. And things like sarcoidosis or lymphangitis carcinomatosis, all these things have this interlobular. Even pulmonary edema, it involves the lymphatic, so this region will be involved. So that is the one thing that we look at in interstitial. The other things that we look at is this kind of appearance. Okay, this is called honeycombing. Okay, so you'll be able to see these cyst kind of things in the peripheral region of the lung. I'll show you more cases, and you will have this row of cells like this. You might be able to see like multiple rows. This looks like a honeycomb. This is honeycombing. This is a classical feature of what we see in a usual interstitial pneumonia or interstitial idiopathic pulmonary fibrosis. The other things that you look at is the bronchial walls. Again, you can see that well in on a CT. You might be able to see the size of the bronchial, the vessel as well adjacent to it. If this bronchus is larger than this vessel, then we call it as bronchiectasis. All right. So, can anybody tell me what this could be? This is an X-ray. This is our CT images. You can just type, or what do you think this is?
Crazy pavement pattern.
Crazy pavement. Okay. I mean, what are the other findings that you're seeing, Nancy? Okay. Can you look at the X-ray and tell me what all you're seeing in the X-ray? Just don't forget these things. Just tell me what is seen in the X-ray. I think X-ray is most difficult, no? Than CT. You looked at this and said crazy pavement. Like, I want you to tell me the whole picture. Can you see these? Okay, these are hidden areas. I told you yesterday, apex, the CP angles. So this one is pleural effusion on both sides. And can you see something here? Some dilatation is there of the left atrium. Okay. Okay, there are some opacities which are seen around these regions. Okay, some perihilar opacities are there. So this CT is showing this smooth kind of, this is the interlobular. See, if you imagine you remember the diagram that I showed you, these are the interlobular septa, these things. And this is a smooth thickening of the interlobular septa. These are HRCT section images. So there is pleural effusion. And there is this interlobular septal thickening which is looking smooth, and there is this dilatation. So it's a pulmonary edema. Okay. All right. So lymphangitis carcinomatosis will usually have like nodular kind of appearance, not very smooth. And this actually, if you see this CT, can you see this is actually a mitral valve? There's a mitral valve calcification. Okay. There's a mitral valve calcification, and the left atrium is enlarged. Even in the X-ray, you can see the left atrium is looking enlarged. All right. So this was a pulmonary edema, case of pulmonary edema. All right. Okay. What about this one? This is again a CT image. I showed you a normal CT. Where do you think these things are situated? Like I just show you a zoomed up image. So remember that like the pulmonary, like interlobular, the secondary pulmonary lobule. So you can imagine this to be one secondary pulmonary lobule, this one to be another one. So the nodules are in the center. Okay. Okay. So these are like centrilobular nodules. All right. These are centrilobular nodules. Okay. This one, this is this I'll just tell you. So if you again you see the interlobular septa, this is what we look at when we see the HRCT. Okay, so this is the interlobular septa. I mean, so secondary pulmonary lobule interlobular septa. These are the central regions. If you see, there is nodularity along these regions. These are all the areas where the lymphatics are present. And if you see, this is the fissure. Okay, this is the fissure. Again, along the fissures there are lymphatics. So if you see periphyseal nodules, nodules along the perilymphatic distribution, lymphatics are also seen around this vessel. So you can actually see this peribronchovascular nodules. That's what we call it. Okay, this is the case of sarcoidosis. Okay, this is how very typical sarcoidosis will look like. You have this fissural nodules like these, and it can have these. Basically, you look at the fissures first. If you see nodules along the fissure, then it's more likely to be perilymphatic nodules, which represents any kind of lymphatic kind of a problem. Okay, again, this is also another case of sarcoidosis. This is just to show that peribronchovascular nodules can also be there, and this, there are multiple nodules in the periphery as well. This again is a case of sarcoidosis. All right, so this is another case, again HRCT sections. This is seen through the lower lobe of the lung. If you remember the things that I showed you, these round things, okay, this is what, this is honeycombing. All right, this is how usual interstitial pneumonia will look like. It will have honeycombing, which is seen in the lower lobes of the lung, like if the things that you see in the, where you hear the basal crackles and all these things in this region where you have this honeycombing. So you have these stacks of this cyst kind of stuff which is sitting in the lower lobes. It will be basal and it will be subpleural in distribution, and it will be more in the lower lobes than in the upper lobes. All right. Another thing that we are noting in the esophagus is mildly dilated. Probably, I think this could have been a case of scleroderma or something which had something. Okay, this is also a case of scleroderma. This is more of a ground glass opacity rather than UIP pattern. More of ground glass. There is diffuse dilatation of esophagus here as well. Centrilobular GGO. Which one were you referring to? Centrilobular GGO? This one? Okay, GGO is like, okay, I'll just come about GGO part again, how to differentiate between GGO and consolidation. So this is this diffuse kind of, like, you know, hazy appearance is what we call as ground glass opacity. Like when it is intermixed with these lines, okay, reticular lines, and these things are actually continuous. So that's what we call it as some traction bronchiectasis when we mention in our reports. Those are also signs of fibrosis. So there is some fibrosis and there is also ground glass opacity. And this is actually, this was actually a case of scleroderma. So this was an NSIP kind of pattern. So UIP will have this kind of honeycombing. They won't, you won't be able to see this that hazy kind of ground glass pattern. It will be just honeycombing. When you have significant honeycombing, you call it as UIP. When you have more of ground glass, less of or no honeycombing, then you call it as an NSIP pattern of ILD. All right, that's just basic. It's not like 100% of what we follow, but that is just basic what we do. So so how do you differentiate ground glass versus consolidation? So ground glass is like this. You'll be able to see these vessels through. If you can see these vessels through, then it's ground glass. This is more like a consolidation kind of thing, where you don't see the vessels through it. So if you see this like really light kind of dense appearance, that would be a ground glass opacity. Ground glass opacity just means there is air which is replaced in the alveoli by anything like fluid, cells, or anything like blood, anything can be replaced. That can cause ground glass. This is actually a case of MCTD, that is mixed connective tissue disorder. Mixed connective tissue disorders will be associated with these kind of peripheral area of this. See, organizing pneumonia doesn't always mean that it will be like a pneumonia, like a consolidation. You can have also have this ground glass kind of peripheral kind of pattern. All right, that is the ground glass opacity. So if you see the vessel, the bronchus looks more darker, that is a dark bronchus, and the vessels look very uniform, you'll be able to call it as a ground glass opacity. All right, this is important to differentiate from mosaic attenuation of like airway disease, or mosaic attenuation which is related to vascular problem. If there is a vascular problem, the vessels will not be the same in size. The vessels can be smaller in size. All right. Okay, this is again, I'm just random showing you cases. Okay, this is a case of ALL. Okay, it's post bone marrow transplantation. Patient has present with febrile neutropenia. This is something you will very commonly see in hemat if you go. Can anyone tell me what this is? I mean, like, do you know what this is and what sign is it is called as? You can just type it in the chat box if you know. Air crescent sign, yes, and see, that's good. Fungal pneumonia, yes, that's quite good. So this is a sign. Yes, yes, it's a fungal pneumonia. Yes, that's good. Okay, so this is a characteristic sign of invasive pulmonary aspergillosis. Okay, invasive pulmonary, I will say, because there is invasion, and this is actually the hemorrhage that you see around. This ground glass thing is actually hemorrhage which is around, and that is the fungal ball. So this air crescent sign comes actually when the thing heals. So you should remember that it's a sign of healing, not that it's becomes worse. So when you many of these hemat patients, when you have like very any sign of fever, they'll immediately take HR sections, and in HR sections this is what we're looking for: nodules with surrounding ground glass opacity. When you see nodules with surrounding ground glass, even just ground glass nodules, you can always think of some fungal etiology being happening there. At the same time, in such a patient, if you're having more of consolidation and more of pleural effusion, then you will think of a bacterial infection. Right. So when you anywhere ground glass in a post for a bone marrow transplant with febrile neutropenia, fungal is the first thing in that we have in mind. All right, so that is halo sign. Halo sign is not specific for invasive pulmonary aspergillosis. It can be seen in others also, like vaginas. It can be seen in few other infections also. It can be seen in air crescent. Again, it can be seen in other things as well. So this is, I showed you halo sign. This is something called reverse halo. Right, so this is what we see in organizing pneumonia, like OP. Organizing pneumonia, the center part will be ground glass, and peripherally there'll be ground glass opacity. Peripherally there'll be consolidation. This one, there is central consolidation or nodule with surrounding ground glass. Here there is a central ground glass, peripheral. This is a reverse halo sign. This is also known as atoll sign. Okay, atoll is actually some island like this. Okay, an island which is in this shape with water going inside this region. So this is atoll. It's also known as an atoll sign. All right, that's organizing pneumonia. All right, organizing pneumonia can have multiple ways of presentation. Like organizing pneumonia is technically a pathological finding. Like what we generally like talk about, like organizing pneumonia, it can be primary or secondary. Primary is what we call as idiopathic or cryptogenic, when you don't know the cause. So secondary is when it is in relation to any infection. Like for example, like you have a peripheral area of consolidation somewhere around, and it's been staying for some time, and you do a biopsy of that, you can have an OP kind of pattern which comes in pathology. Okay, it doesn't mean that it is COP, like a cryptogenic organizing pneumonia. It may be related to some infection which would have been there. It can be in relation to some viral infection or fungal infection or bacterial infection. It can sometimes be related to even radiation, all these things. Drugs also, it can cause this OP pattern. So OP is a very, very varied pattern. Even that crazy payment, I think that you mentioned earlier, so one of you has mentioned crazy payment. It can be seen in organizing pneumonia. The crazy payment kind of pattern can be seen. You can have this kind of halo, reverse halo sign. You can have peripheral areas of consolidation, like peripherally like that, or like the previous MCTT picture that I showed you, peripheral area of ground glass. It can also look like a mass. It can look like a proper mass also, and organizing pneumonia. All right, so that is about lung things. So with regard to the bronchus, like you look at, I told you bronchus, we look at the size and the way in which it is sitting. So this is irregular, it is dilated. So how you say it is dilated is when you compare it to the vessel which is adjacent to it. If it's larger than the vessel, it is dilated. Right, this is what we call as a traction bronchiectasis. So basically, because of fibrosis in a UIP and some kinds of fibrotic NSIP, also you'll be able to see this. Because the fibrosis, these walls get pulled and the bronchial walls remain more dilated. That's called a traction bronchiectasis. This is what we see in areas of fibrosis. This is not the normal bronchiectasis that we see. You can have other kinds of bronchitis like in alpha-1 antitrypsin and all these other conditions where it may not be associated with this kind of fibrosis. All right, so anybody to take this one? There's an X-ray and quite self-explanatory. I mean, sorry, CT. Anybody has any idea what is happening here? No idea. Okay. Left lung collapse. Yes, that's very good. That's a very good thing. pleural effusion. Excellent. Okay. So there is definitely some collapse. So like whenever you see an X-ray, you look at volume loss. So first thing you look at when you see kind of this kind of fully like opaque hemithorax, you need to look at. So why she said lung collapse other than looking at the CT is because there's this tracheal deviation to this side. I told you like on an X-ray normally it can be deviated a bit to the right, but usually never to the left. Okay, so this deviation to the left side is because of the collapse of this lung. If you see the mediastinum is also shifted to that side. All right, if you draw a line in the center, usually the aorta is seen here, the pulmonary artery will be seen somewhere around this line. This whole thing is shifted to this side. Okay, and of course there is this lung is completely, you are not seeing any air inside this region. This lung is completely collapsed, and this is the effusion. So the difference of in the importance of doing contrast is to make out that there is this areas of like enhancement, which will probably be like lung, normal lung, if you can see these regions, and this is inside this collapsed lung. This is the collapsed lung that I'm showing you. Okay, inside the collapsed lung you can see this hypodense area, no, that is actually a mass. All right, so and in addition to that, there's this pleural effusion. This is more hypodense and it's outside this region of this collapse. So this is in the pleural cavity and it's very hypodense. This is like fluid attenuation. This is how fluid would look like. So this fluid attenuation is pleural effusion, and this thick bright line that you're seeing all around, that is the pleural thickening, right? So there is some pleural thickening. There is this collapse. Okay, and there is this mass which is sitting there, and this is the right pulmonary artery. The left pulmonary artery is coming till here and it's getting occluded. All right, we are not seeing, I don't have the contiguous sections, but this is completely occluded. And not just that, the bronchus, this is the bronchus. Okay, this is the left main bronchus. You can see the mass is going into the left main bronchus like that. So this is how a malignancy will probably look like. So things you look for in a when you see a left lung collapse, to look for in a malignancy. Vessels, very important thing to look for ruling out. Then additional findings, like if you see metastasis or if you see nodules in the opposite lung, you see this kind of pleural thickening. All these things are pointers towards a malignancy. All right. Okay, this is just to show you hydatitis. I think, I don't know, it may be important for you from exam point of view. So hydatitis in the lung are actually very, very thin walled cysts usually, and they can be like multiple. They can be well demarcated. This is cyst. You remember I showed you this fluid attenuation. This is how this fluid attenuation will look like. Okay, that is again a cyst. These are multiple hydatitis cysts which are like well defined and seen separate from the lung parenchyma. All right, so we just talked about like generally what mostly about parenchymal things. We just like talk few things about pleural disease. So pleural disease, it can I told you, contrast is very important for assessing the pleura. You'll be able to make out enhancement, thickening, nodules, and presence of empyema, all these things only on a contrast. And this is just to show you metastasis. So if you see thickening of the metastasis, in metastasis they'll be quite irregular, very thick and nodular kind of appearance. And the involvement of this mediastinal pleura is one of a very significant sign that this could be a malignant pleural thickening. If it along this costal pleura, it is not as sinister as when the mediastinal pleura is involved. All right, this is a metastatic ovarian carcinoma which had a malignant pleural effusion. This is a tubercular effusion. If you see, this had this nodularity. This one is looking a bit more smooth. All right, so this is a loculated pleural fluid thickening and enhancement of the left-sided pleura. This is a tuberculous pleural effusion. All right, so other than pleura, parenchyma, bronchus, the next thing is to look at the vessels. Okay, I think this is very, very important from an emergency point of view. Like when you send for a CT pulmonary angiogram, we try to make sure that the pulmonary vessels are opacified properly. So doing a routine CT thorax doesn't mean that the pulmonary vessels are covered, because the contrast is given at one point and the images are taken at different point for a normal arterial study as against a pulmonary arterial study. So like don't expect to like, you know, maybe you'll be able to tell the main pulmonary artery and the right and main branches, but the rest of the vessel you won't not going to be able to rule out a pulmonary embolism in a routine CT thorax with contrast. You need a specific pulmonary angiogram study for it. So the pulmonary angiogram study is, we give lots of like much more contrast than usual, and we make sure that the right side of the heart is nicely opacified, and like here both the aorta and the pulmonary artery, this aorta is on the right side, the pulmonary artery are opacified. Usually they do something called a split bolus technique so that both are opacified, and sometimes you can just give like single bolus technique where only the pulmonary artery is also opacified, but this is what we usually follow, where aorta as well as the pulmonary artery are opacified, and we kind of try to trace the pulmonary artery. Like we start from the main pulmonary artery, go to the right, go to the upper lobe branches, middle lobe branches, lower lobe branches, like that. Each of the segments we'll try to opacify, and we look for this filling defect. So the filling defect is actually because of the thrombus. So the thrombus is going to look less dense as the contrast. So like a partially eccentric filling defect, that's called a rim or Polo-Mint sign, where you have a central filling defect from the thrombus which is surrounded. This is the Polo-Mint sign that we see in a pulmonary embolism. All right. So this acute pulmonary embolism, usually the vessel will be dilated, just like how you see in an acute DVT, the vessel will be dilated a bit. A chronic pulmonary embolism is not like that. The vessel may not be dilated. You might be able to see an eccentric thrombus like this. Okay, or you might be like able to see like some strand like this, or you might be seeing the vessel which is much smaller in size. So these are the things that you see in a chronic pulmonary thromboembolism. All right. So I just show you few cases. Yeah, if anybody can like either talk or chat, whichever way. I've given you the history. What do you think is happening? Um, at least tell the obvious first. What is most obvious in this X-ray? What you shouldn't be missing in this X-ray? Anybody? Yes, both CP angles are blunted, not just the left side. Then, so I told you there's a previous history of TB. Okay, do you think that could be like related or anything, or do you think there's anything else which is abnormal with it? Okay, it's a little bit a tricky case. It's a young patient also. Okay, so I'll just go through this quickly. Okay, so that's a trachea. This is how I'm going to view the X-ray. Trachea, the bronchus I'm seeing, then again the heart borders I'm seeing. I can see that this is a bit, so I can see that this side is looking a bit bulged, like it's more prominent on the right side, but there is this deviation. If you can see, there's rotation to this side, which is probably the reason for this side to be more apparent. There is definitely this blunting of the CP angle which is seen. I'm going to look at the lung fields on both sides, lung fields on both sides, and I'm seeing the bones. Can you see this thing? Does anybody see this? And see this depression here, and see this? I don't know if anybody noticed it. Okay, I don't know if anybody, there's a rib notching. Okay, the 5th to 8th rib, there's a rib notching. Okay, all right, this is actually a coarctation. Okay, so don't miss the like this the more subtle things. Just because you see one finding doesn't mean that that is the only finding which could be there. This is actually a case of like aortic coarctation in this patient. So make sure you see everything, not just stop at what you're like seeing, what you see first. Make sure you see everything. And if you have a protocol to follow, you will not miss these findings. All right. Another one. If anybody can notice where the abnormality is, I think that should be fine. I've given you a history. At least tell me where the abnormality is. You don't have to tell me a diagnosis. Like which part of the thorax is the abnormality seen in? It can take a bit of time. little bit time you can take, I guess. Few more seconds. Ribs, I mean, you're talking about the current case, no? In this, no, the ribs are okay. Anything else? It's also one interesting case. I told you again, history of stroke is there. Nobody is picking up anything. Okay, I'll just start again. Again, trachea. Okay, left lobe. No, not the left lobe. Left lobe of the lung, you mean, right? Yeah. Nothing in the left lobe. Which side? Left lower, upper? Is not at all on the left lobe. Descending aorta is normal. Yes, it's normal. Descending aorta is normal. Anything else? Because it's a stroke, you thought descending aorta. I get it. Vertebrae. Oh, no, no, no. Vertebrae also normal, John. Okay, whenever you don't see anything, where do you look at? You have to look at the review areas. So just look at the review areas. You will get it. I'm sure it's projecting quite decently. It's in the lung. Yes, very good. Right lower lobe. Excellent. Okay, can you see this? Okay, you saw that? So there's a lesion, yes, behind the diaphragm, retrodiaphragmatic region. There is this lesion here. Okay, don't forget the review areas. Don't forget the review areas. Okay, this patient presented with a stroke. There is this nodule which is seen here, and if you see this there's this vessel which is leading up to it, which is looking a little big. Okay, like what do you think it could be? Can you like say anything more? If I say this vessel is looking big, there is this nodule here, and the patient presented with a stroke. Can you think of anything? Could the patient be having? Maybe I can help you with. I don't know if I have a CT images. I'm not sure. Okay. All right. So it's a lung AVM. All right. It's a lung AVM. Okay. It's an AVM. All right. It's an AVM. So this AV malformation was there. I'll just show you the CT image. Okay. This is a dilated feeding vessels were there. Okay, and the nodule was supplied by this. So like if I give you more history, that the patient also had epistaxis, cutaneous telangiectasia, what do you think the diagnosis is? I'll wait for some time if you want. So I told you AVM is there. Patient has epistaxis, history of epistaxis. Patient also has telangiectasia, cutaneous. Excellent. Very good. Very good. Okay. So that's an Osler-Weber-Rendu syndrome. Okay. HHT. All right. Good. Okay. I'll just show you some more cases. I don't know if this is projecting well, but I don't know if this is projecting well, but I don't think this is projecting so well. Anyway, okay, this one we'll just take this. Okay, the patient who presented with chronic cough. Where all do you think the abnormalities are? I've already put like arrows as to where it is. Can you think of what it could be? What all is happening in the lung? Okay, he's presented with chronic cough. Okay, there is this opacity which is seen on this side in the left upper lobe. Okay, and there are these smaller nodules, like things which are seen here, small tiny things which are seen. Yes, TB, yes, but like okay, TB, yes, definitely there is TB, but there's something more to it. There's something more to it. So if you see, yes, there is all signs of TB. Okay, like if you not left phrenic fallacy. No, no, it's actually this hilum is pulled up. Okay. Um, this hilum is pulled up. If you can see this hilum, this is a fibrotic band which is pulling the hilum upwards. Okay, there's this nodule kind of thing inside this thing, and can you see this line, one crescent kind of thing? Okay, I show it a CT. Okay, that's a CT. All right, this is the myosarcoma. All right. Okay, all signs of TB are there in this. Okay, volume loss, all those other things are there. Then there is this cavity, and there is this air lucency around it, and this is a myosarcoma or fungal ball which is seen in this patient. All right, and these nodules that you saw on the other side are just calcified nodules. Some calcified nodules which you've seen, probably related to the TB before. All right, one more. This is a young man who presented with cough, weight loss, and fever. This is something you might just probably encounter in an OPD or something. What do you think is the abnormality, and where do you think could? Okay, this nobody should miss this. Okay, this is a miliary appearance. Okay, does miliary appearance mean just TB? No, it doesn't. All right, it can be seen in a lot of things. Okay, like for example, like you can have miliary metastasis. Sometimes fungal infections can cause this. Okay, if they are more dense, you can have some varicella zoster related changes in the lung where you have these nodules things. It can be because of sarcoidosis, or it can be because of like silicosis. So there are multiple things for this miliary kind of appearance, but TB is what we see here more commonly. All right. So this again is disseminated TB. You can see why multiple nodules which are like everywhere. I told you that miliary is like more like random distribution. It will be seen almost like everywhere. Okay, non-calcified, randomly distributed throughout the lung. Okay, that is a disseminated TB. All right, this one. Okay, this is also a very tricky, nice case. Just tell me, I want the whole picture. Why did you say cannonball mitts? Why can't it be like some other infective nodules? If I say vaginos, or you know something else is there. So don't just stop at what you're seeing. Okay, okay, always ignore the obvious. All right, always ignore the obvious, look at the other things also, and then you arrive at a diagnosis. Okay, if I showed it this to you as a spotter, yes, I would say okay, cannonball metastasis, but it's not just a simple spotter. There's a little bit more, something more to it. If you think it's metastasis, yes, very good. It's not missing, it's there. All right. So like whenever you see something like this, if you think it's metastasis, keep looking for findings. Okay, keep looking where it can be. It can be anywhere. It can be in the clavicle. Maybe you'll find some met here, some bony lesion here. It can be one of the ribs maybe got eroded. Maybe one breast could be absent. This is not a complete mastectomy. Actually, the patient had a uh, an implant. Okay, this is post mastectomy. Patient had implant, and the implant are also kind of like broke, and this is the implant which is broken from the membranes which are broken from inside, and these are the metastatic nodules which are seen. All right, and like when you see metastatic nodules, they'll be very well defined on CT also, just like how you see on X-ray. They'll be very well defined. They'll be look like proper cannonballs. Okay, different sizes and shapes may be scattered in both sides. All right. Okay, this one again quite simple, I think. Very simple, I think. This one, this could be one of your spotter cases, I guess. Sarcoidosis, yes. So why? So this is sarcoidosis again. Okay, okay. Why can't it be TB? Can it be TB? Can it be TB? Sarcoidosis usually presents with this bilateral appearance. Okay, TB like rarely presents with this bilateral kind of adenopathy kind of appearance. Okay, this is right paratracheal. So 1, 2, 3 sign it's called. Okay, right paratracheal and bilateral adenopathy. So like if you see parenchymal abnormalities, again the staging changes. You will be knowing all that. All right. Okay, that is sarcoid. Okay, this one. Again, interesting case. What do you think is happening on this side? Gall and triad, yes, Rakul. Okay, this, can anybody tell me what is going on in this side? Eventration, okay. Anything else? Eventration will usually have the, you usually maintain the, like this eventration is usually partial or complete, okay? So partial or complete, like I'm just telling you because you said eventration, okay? So eventration can be partial or complete. Like partial is what we commonly see. Yeah, complete is not that common. Eventration, when you have partial, you'll see one like bulge like that, okay? It will be like a little bit seen like that, okay? It will have a curved upper margin, right? That is how an eventration will look like. Or the whole, when you complete eventration, the whole diaphragm will be looking up like this, okay? This has kind of this, like, you know, it's like linearly, it's like slanting down towards this side. Okay, collapse. All right, then, okay, why this is okay, this is a little bit difficult, I guess. Okay, so there is this density which is seen, okay, and diaphragmatic fillet, yes, both right cardiac, yeah, right heart border as well as the right hemidiaphragm is involved, so it's the right mid and lower zone, okay. Other thing is, if you see the left diaphragm, it's you remember somebody said about smoking last time, okay. This is left hemidiaphragm which is looking slightly like flattened. Probably the patient is a smoker, so I would think of probably malignancy in this case, right? So they did a CT on this patient, all right. This is the collapsed lung which is seen on that side. This is part of the right lower lobe which is collapsed, which is seen here, and there is this endobronchial mass here, all right. So that's this endobronchial mass which is sitting inside and which has caused collapse of this lung, okay. All right, okay, that's all. I hope, I don't think I'll be able to cover whole of CT in one session. I think basic things is what we have tried to cover. That's all. If you have any questions, I can take now.